Good morning, everybody, and I thank RIC for inviting me and being part of this fantastic academic opportunity. I'll be talking about a very specific finding that we see not only in CSCR, but in several different diseases that have a choroidal origin, that is the choroidal HRF, and I'll be presenting a case where it sometimes becomes difficult to diagnose between two entities. No financial interests regarding this topic. Now, what are choroidal high reflective foci? They are small, well-circumscribed punctiform lesions, initially described as high reflective foci in the retina, but then people observed it in the choroid also. In the retina, usually it is, the boundary that is given is about less than 30 micron. In the choroid, several studies have gone from 50 microns to almost 2,000 microns. These have high reflectivity similar to the NFL layer and have a scattered distribution in the choroid. And they have been reported in a wide variety of cases. They've been reported in normal individuals, very commonly in retinal degenerations, in vascular retinopathies like diabetic retinopathy, and also in CSCR and choroidal inflammation. Now, there are several ways to look at it, and you can look at them in the on-fast or in the B-scan images. What is their origin? Very doubtful. People say that it could be migration of RPE cells with lipid components in degenerating retina. So in retinal degenerations, it could be that. It could be stromal localized cell proliferation of microglial cells, melanocytes or fibroblasts in chronic conditions like chronic CSCR. It could be exudates of macrophages or WBCs in inflammation, or it could be just a simple chronic fibrotic response to choroidal congestions. So nobody knows for sure, but these are the possible origins. Choroidal hyperreflective foci are seen in acute CSCR, but much less common than in other conditions, only in about 30 or 33% of cases. The counts and densities are lesser than compared to the fellow eyes and normals usually, and mostly they are seen in the choriocapillaris, and they could be related either to bogginess or to ischemia. Choroidal HRF in chronic CSCR are far more common, seen in up to 80% of the cases. Their density and counts are higher than in acute CSCR. They are very prominently seen in areas that have RPE damage or window defects. Their correlation is higher with thinner choroid, so it is inversely related to the choroidal thickness, and they are higher in patients that have CNVM as a complication of CSCR. Choroidal HRFs are very prominently seen in cases of choroidal inflammation, VKH being the prototype disease, where you see a lot of these hyperreflective foci, more in the choriocapillaris, but scattered throughout, and the numbers do reduce with treatment. Now, with that thought in mind, I have a very interesting case which I would like the panel to discuss. Now, this was a 23-year-old man with a history of decreased vision about 10 days, no clinical signs of inflammation, no retrolental cells, no pre-retinal cells, and this is how the OCT looked like. Thickened choroid, a lot of hyperreflective foci, a little bit of SRF, and underwent an FFA, and had this multiple punctate hyperreflective lesions and a bulla of fluid. The disc is not hot. There are no other signs of inflammation. So what could this possibly be? CSCR, inflammation.
How's the other eye?
The other eye is perfectly normal. And no history of steroid intake or no history of...
do you have the images?
Pardon?
Do you have the images of the other eye?
It's not in this presentation, but I have it. I mean, I can show you. It's a perfectly normal eye.
Panelists, any thoughts?
CSR to me. It looks like pinpoint hyperfluorescence.
I would also not favor CSC.
Yeah, I would also agree that like it doesn't look like a CSR at least. Though the disc may not be hot, but doesn't mean that like it's...
Correct. So if you look at the literature, they say that hot disc is a sine qua non of VKH, and we also thought that the FFA is more like an inflammatory disease, but this fact that the disc was not hot was a little troubling to us. Anyway, since we also agreed with the panel, we thought this is more of an inflammation, not of a CSCR. The patient received steroids, and this is what happened. The fluid increased. So now, what would be the next course of action?
How many weeks after this?
Yeah, so the problem, this patient is in a place where the ICG is not available. He is in Bikaner, so we don't have the ICG there, but I mean,
Are there significant striae in the posterior pole, retinal striae? I mean, on that.
A few, yes, a few. Few are visible, ma'am. Which is again goes against CSCR, but there are visible striae.
So did you stop treatment with steroid?
So what we've done is that we've called him again for FFA. This case, this response came just about 3 days before I came here. We've called him again to repeat an FFA and to see whether there is now an additional ink blot leak. Whether this was a case of inflammation initially, that also is a steroid responsive case and developed increase in fluid because of the steroid. If that is so, then we'll have to go to immunosuppressants, a fairly high dose of immunosuppressant right away. If not so, then we have to scratch our heads a little more.
Can I just ask one question here?
Yeah, Madhu.
Yeah. So what was the dose with which you are treating this patient with steroids? Like what you said, could it possibly
He
have been
received
a fact-
60 milligram. He received Visolone 60 milligram.
And
oral.
how long after steroids has this happened now? How much?
6 days.
6 days.
Yeah.
Could it possibly the fact that you need to keep the patient on a long-term treatment probably for the effect of the steroids to come, and what we are seeing right now is just a progression of the inflammatory disease?
It could be possible. It could be possible. That's the reason why I called him again back for an FFA to see whether it is now a CSR, that is, I mean, it was case of steroid responsive and developed a CSR, or it is just the inflammation.
What has happened to the choroidal thickness after the treatment?
It's almost the same, sir.
if you look-
The lower panel, if you see, it's almost the same. Nothing has changed.
The choroidal folds are quite significant, and the type of leakage is again not something which you would see in CSR.
In CSR, correct, sir.
We do have a few patients who are like this, who are kind of borderline between CSCR as well as an inflammatory disease, and don't seem to get better with steroids also. We also haven't found a solution to that. But then like repeating an FFA would show us if at least the leakage from the choroid, the RP defects has decreased or not. So that should probably give us some information, I would think.
Also, just one last point would be if you compare the previous OCD with this one, I am not sure, but I believe that the RP undulations have started kind of reducing in this as compared to what you had. And RP undulations are the first sign of resolution in inflammation. So
Quite
probably
correct. So this could be unilateral VKH, an early form could be a possibility, but usually in VKH what we see is that the RP undulations are far more pronounced than this. They are, the kind of undulations that they call the bumpy, lumpy RP. You see it far more pronounced in VKH.
would also help if you get a B scan done, because that can also be a posterior scleritis rather than.
No history of pain. It was done. So, posterior scleritis is ruled out.
Yeah. So pain is not necessary for scleritis to happen, but a B scan probably if you look at the fluid, that
Yeah, it
can
has been
probably-
done.
Okay.
It has been done. It's quite normal.
Thank you.
And having a unilateral CSC with such extensive, similarly unilateral VKH is also very unlikely in both senses. So I think scleritis is towards, like I would be thinking in that direction. But one thing I really want to say is that I was collecting case series of patients with CSC who presented with bullous detachment and had disc leakage on the FA. Because I had a patient where I thought disc leakage, so we stopped the steroids. Obviously, the person who saw before me, they continued the steroid, and when I saw the disc leakage, but I was in favor of CSC, I stopped and it turned out to be a CSC and I had a 7-year follow-up. So I think having a disc leakage is always possible if your retina is detached and you have so much exudative RD already because of CSC also. And I think choroidal folds have a very high association with CSC. We wrote a case series recently. I'm not sure if it got accepted, but the choroidal fold is one of the most common other ocular finding associated with CSC. So I think Abhishek maybe continuing the steroid for 1 more week, 2 weeks, that will give us some hope. Thank you. Keep us posted.
Thank
Thanks
you.
for sharing.
Thank you.
All right.